I'd just shout out to Dr. Kavanaugh and Kathy and HealthWatch USA for having this meeting, which has really been instrumental in this story about cobalt problems with hip replacement. This is something I've been pursuing now for nearly 10 years, since I had one of these implants myself and realized there was a problem that nobody really wanted to admit existed within my professional circles or within industry. But what we're here today to focus on is what we're finding is a progressively common problem with hip replacement surgery in the United States and in the world as it is presently practiced today. And this is an evolution. When I was in New York City in 2013, I believe that the problem was limited to a large group of patients, but a technology that quickly became disfavored and is no longer commonly used, called metal-on-metal hip replacement. And the big news over the past 5 years for me, but particularly the past 3 years, has been that I am now commonly seeing these problems in most patients with hip replacement, with a proviso being that hip replacement has a chrome cobalt part. So it doesn't need to be a metal ball rubbing on a metal socket. It can be a metal chrome cobalt ball rubbing on a plastic socket. And it can even occur if the ball is ceramic rubbing on plastic, if there's other parts of the hip replacement that are made of chrome cobalt. So I think this is a critical slide, and when I go to my professional meetings, nobody spends much time on this slide, because if they went into who they've consulted for and how much money they've been paid by various arthroprosthetic companies, the entire 30-minute talk would get absorbed with the disclosures. I don't have any economic conflict of interest, and that's critical. I am passionate about this problem, first of all, because I personally experienced it, and had I not personally experienced it, I would have never recognized the problem. I'm also passionate about the problem because once I recognized it myself, I started to recognize the same problem in the 6 patients that I had personally put metal-on-metal hips into as a surgeon. And that occurred over a period of several years that I followed these patients up and realized what my profession was telling me was a rare complication of a very popular technology at the time, and some were doubting that the complication existed at all. And over time, slowly, people got to admit, oh, this really does occur, but they're continuing to insist that systemic cobalt poisoning from hip replacement is a rare occurrence, even with metal-on-metal hips, which are no longer commonly used. And this is counter to my experience in my own patients. It's actually quite common. And then what has occurred over the past couple of years, which I'll get into in great detail, is I'm now seeing the same problems in patients with much more commonly performed types of hips. The differences are subtle. It takes longer to present, and the patients don't have the same degree of elevation of cobalt in their blood and their urine as the metal-on-metal patients did. And the cobalt is being produced by a different mechanism. It's being produced by corrosion at these modular junctions between parts and pieces. And I'll show you pictures of that. But the take-home message today is that cobaltism, or systemic cobalt poisoning from a hip replacement, is a common problem. It's not limited to metal-on-metal hips, which are no longer commonly used, but still popular among some surgeons in an application called hip resurfacing. But most Americans with an artificial joint, with an artificial hip joint, and hopefully somebody in the question and answer period will ask me whether or not this might apply to other joints, are at risk for this problem if their joint replacement has a chrome cobalt part or piece. And of the 4 million Americans in the United States that have prosthetic joints, most have a chrome cobalt part or piece. So what we're dealing with here is a common problem, but it's uncommon for it to be recognized among medical providers. So the primary problem with the human body and cobalt is its effect on the neurologic system. Its effects on the heart have actually better known among medical providers. But what makes people sick the quickest are the neurologic issues. So we've coined a term for this, arthroplasty cobalt encephalopathy, or ACE. It's a clinical syndrome, and it's somewhat difficult to sort out from the normal aging process if you're dealing with an aging population. And if you're dealing with joint replacement patients, you're dealing with an aging population. And I think this is critical to why this problem has been under-recognized. But when I look at Dr. Chramium and other internists, Dr. Elders who practice medicine, and they take a look at these symptoms, fatigue, cognitive decline, disordered mood, motor sensory dysfunction, they're saying, gee, that's my waiting room, Steve. These are common problems in an aging population. So what I hope to convey today to medical providers and to patients is how you sort this out from normal aging. When do you get concerned? When do you check a urine cobalt? And when do you pursue the workup further? So first is a concept, and again, I encourage somebody during the question and answer period to ask, gee, Dr. Tower, does this risk extend beyond hips? But let's limit it to hips for the purpose of this talk, because that's the population we're dealing with today. People need to throw away the idea of metal on metal hip, metal on plastic hip, ceramic on plastic hip. And you need to substitute the term at-risk hip. An at-risk hip is one that contains any chrome cobalt part. It can be a chrome cobalt ball. It can be a chrome cobalt neck. It can be a chrome cobalt stem. It can be metal on metal hip with a chrome cobalt ball rubbing on a chrome cobalt socket. All that matters is it contains a chrome cobalt part. Most hips done in the United States over the past 20 years contain a chrome cobalt part. Most patients in the United States with a hip replacement are at risk for this problem. So we're going to focus here on Dr. Bridges and my experience over the past 3 years, really. 3 years ago, I was understanding that I was seeing the same problems I saw in my metal-on-metal hips in my metal-on-plastic patients, which was a much greater group numerically. I was noticing some differences. Their cobalt levels were not as high. They were getting into trouble significantly later on, 8, 10, 15, 20 years after hip replacement. But I was getting the same story from my patients about fatigue, about cognitive decline, about Parkinson's disease, where there's no family history of Parkinson's disease. And I'm saying, gee, this is deja vu all over again. Only I didn't appreciate that these patients were at risk, because I only thought that would occur with metal-on-metal patients. And when I checked their blood cobalt levels, these patients generally had a blood cobalt level that was 1 order of magnitude less than what I had been seeing in the metal-on-metal patients. And then I was down in, radiologists hang out in the basement and the ground floors in dark rooms. And in my new office, I wandered down to go over an MRI of a hip of a patient that had a metal problem at the hip. And when you get this chrome cobalt debris around the hip, whether it's a metal on metal or a corrosion problem from all these other hips, the tissue around the hip can die or get intensely inflamed, which may or may not be symptomatic. And you can't see it usually on plain X-ray, but you can see it with various cross-sectional radiology imaging, MRI, ultrasound, and CT scan. So I went down there, and Dr. Bridges was pinch hitting for Dr. Beck, who was a regular radiologist. And I told him this whole story of woe about the metal-on-metal hips and the neurologic problems, and we were looking at this MRI of a patient with a metal-on-metal hip that had the issues at the hip, and he just kind of lights up like, he's a pretty bright bulb, and he really lights up. He goes, wow, send me one of those patients, and we'll do an FDG PET brain scan on them. I didn't know what the heck an FDG PET brain scan is, but you will all know by the end of the day. So that is the genesis of this series. Over a period of 30 months, I've had 101 patients walk through my threshold with an at-risk hip. All those patients consecutively have gotten a symptom interview or inventory about the 12 most common symptoms that I was able to extract from my own personal experience and from the literature about cobalt poisoning. And we also got a urine cobalt level on them. And those patients that had 2 or more symptoms, not all of them, but the ones that had the most number and the ones that seemed the sickest, I sent them downstairs to Dr. Bridges, and he dosed them up with a radioactive fluorine molecule and looked at their brain metabolism. And all of a sudden, we went from an entity that everybody was dismissing as, gee, Steve, these are just your patients getting old. People develop these things as they age. We could see it. We could image it. We could see it on brain scan. And it doesn't look like normal aging. So that is really what has blown the doors off this problem over the past 3 years. So our present series, 101 patients screened with at-risk hips, 57 of which are peeing cobalt. So that's what we consider to be a cobalt-positive patient. And of that 57 that are cobalt positive, we've gotten FDG PET brain scans now on 28, not 25. And they are all crazy abnormal in the same fashion. So the take-home here is this is a very common problem. This is the 12 symptom inventory. I personally experienced 10 of the 12. It wasn't a lot of fun. I was spared the peripheral neuropathy and to some degree the forgetfulness. Unfortunately, my executive dysfunction was relatively subtle related to complex spatial relationships, which is something we've seen in our patients over time when we put them through full panel neurocognitive testing. But with this particular series, knowing it's just going to be totally dismissed by industry, by my colleagues, I said, well, let's just look at the 25 out of 101 patients. I love the 101. It makes math easy. So, we're looking at a full 25% of the screened population that by FDG PET brain scan have a serious brain metabolic problem. And these patients, and Dr. Bridges are going to get into this, generally do not have structural changes in the brain. And again, what we're seeing on brain imaging fits with a toxic entity. It doesn't fit with Alzheimer's disease. It doesn't fit with straight up Parkinson's. But these patients' blood cobalt levels, these are the scan patients, are right around 4 parts per billion. This is very notable because orthopedic surgeons do not get excited about a blood cobalt level of 4 parts per billion. Because when we were worried about metal-on-metal hip replacements, the initial word out that patients didn't tend to get trouble at the hip until their levels got up to 7 parts per billion. And even those orthopedic surgeons that eventually were willing to admit that systemic toxicity could happen related to metal-on-metal hips. They didn't believe it would happen until the blood cobalt level got above 10 parts per billion. So my patients that we know have a problem have a blood cobalt level that is much lower. These patients were fairly average age when most of them got their hip replacements right about the age of 60. The hips had been in on average of about 9 years before we screened them. And the average amount of time before they started to experience neurologic issues was about 7 years. Now, although most of the patients had some degree of symptoms at the hip in question, generally the neurologic symptoms preceded the hip symptoms. And this is very, very critical because what literature we have, what recommendations we have from orthopedic professional organizations, from the FDA in the United States, from the MHRA in the UK, kind of says, well, you don't really have to worry about the possibility of cobalt issues at all unless patients have symptoms at the hip. That's particularly the American line, where there has not been any recommendation for routine screening of patients, even if they have metal-on-metal hips, which we know are a big problem. So of this group of 25 patients that got scanned, we've actually revised the hips and got rid of the chrome cobalt in 13 patients. Many of these patients are confounded by having another joint on the other side, a prosthetic hip that's at risk, and many of these patients also have other total joints that have modular chrome cobalt componentry. So of the 13 revised patients, we've only followed 9 patients out more than 6 months post-revision. 2 of them, their cobalt levels didn't go down after I revised that particular hip. And that's because they had multiple other sources of cobalt. And the patients whose cobalt levels didn't go down didn't improve. Of the patients whose cobalt levels went down, all but 2 did improve at 6 months post-surgery. And we've had the opportunity to re-image 4 of those patients, 2 of the patients who did not get better, and 2 that did. And again, I think it's showing, and Dr. Bridges will get into this, I think it's showing the utility of the FDG PET brain scan, not only to make the diagnosis of ACE, or arthroplasty cobalt encephalopathy, but also to follow the patient's response to treatment. Bob is going to get into this in great detail, but this is what the Neurostat program, the more visual program that looks at. When I was first looking at these, and we don't have the particular view I was looking at, if you look from the top of the brain down, to me it looked like a headless polar bear skin rug. And that was, for the first 8 patients or so, this was the only program we had to analyze these studies, and I thought that was kind of the pathognomonic sign, but that was very visual, and we're better than that now. So the bottom line, this isn't just a metal-on-metal problem. This is one of our case reports of a pilot who lost his air service because of rampant Parkinson's disease that did not, was severe enough to require a deep brain stimulator. He developed this problem well before he developed symptoms of his bilateral Biomet Magnum hips, which, although they're no longer on the market, have never been recalled, and there's no systematic screening program for patients that have that particular implant. Bottom line is, very high cobalt levels, post-revision, his Parkinsonism all but resolved. And he's a published case report. How many nurses do we have in a room? So this lady is a perioperative nurse at one of the institutions in Anchorage. This is a metal-on-metal total hip replacement. She would see her surgeon pretty routinely in the halls. How's the hip? Oh, the hip's fine. You know, what he didn't know to ask is, well, how are you doing otherwise? She had developed significant cognitive symptoms, was worried about the quality of her patient care, could no longer start IVs because of her tremor. Finally, she presented back to clinic because she injured her back at work. And that was my former group practice where there was some awareness to the problem. The PA who saw her was aware that there was a potential for cobalt poisoning, checked her cobalt level. It was sky high. She went on to revision with resolution of symptoms. This is a relatively elderly woman with a modular hip replacement with a corrosion problem. This is a metal on plastic hip. It's really not on medical providers' radar as being a hip that might produce systemic toxicity. She has the same symptoms as a metal on metal patient, but her blood cobalt level was only 11 parts per billion. Much lower than we're used to seeing with the systemic problems with the metal on metal hips. Same story. This is actually a recalled implant because of the problems at the hip, and she did have severe problems at the hip. But same story. A year after revision, most of her systemic medical problems resolved themselves. This is my patient, one of our patients, unfortunately, that has not improved over time post-revision. Even though we did resolve his elevated cobalt levels, he had a severe problem at the hip. I had reason to revise him at the hip. That black crap that you see, that what you're looking at is the surgical wound with the hip dislocated into the wound and the head has been disengaged from the taper. And all that black crap is the corrosive debris. This is a non-recalled Stryker Accolade Chrome Cobalt HGFX stem with a non-recalled Stryker 32 millimeter Chrome Cobalt head. Stryker was the same company who made the Rejuvenate implant that was recalled. Again, this particular implant really is not on medical providers' radar as being a potential problem. Particularly problematic in this gentleman because the stem was made out of chrome cobalt. I had to split his femur in half and remove his stem in order to get rid of all the chrome cobalt, which is a pretty morbid operation to do on a now 78-year-old gentleman. And I'm running into that particular problem more and more often and having to lean on the arthroprosthetic companies sometimes to make me custom adapters so I can leave a stem in if it's titanium and put a ceramic head on it, because these tapers are non-standard and some of the older titanium stems are not supported in terms of being able to put a ceramic head on it. And I won't go into a revision surgery and leave a patient with any remaining chrome cobalt. I think with what I know as a provider that would be malpractice. So we've discussed the systemic issues. Again, as far as most orthopedic surgeons in your community, most orthopedic surgeons in the world, their belief is that the systemic complications are rare and reportable. However, they are recognizing that the periprosthetic problems, the tissue damage, the loss of tendons and muscles, that is getting recognized more and more often. What I need to do with my orthopedic colleagues is bring them up to speed, say, hey, you know, when you recognize a patient that's got the problems at the hip, dollars to donuts, they've got the problem at the brain as well. And you might look at their heart too before you do revision surgery. Systemically, who here knows what progeria is? Anybody? Okay. Progeria is a rare medical syndrome of accelerated aging where children turn into old men and women very quickly. I think of cobalt as a toxic progeria. It just makes aging occur quicker. And that fits with the pathophysiology of heavy metal poisoning. So where are we at? In 2016, this case series was published in the Journal of Public Safety. At that time, we could only identify 25 case reports in the literature of cobalt poisoning by hip replacement. Cobalt poisoning has been recognized by other means of exposure in the past. All those case reports are extreme. These are patients that came in heart failure and were deaf and blind and also peripherally severely neuropathic. And a lot of them also had thyroid changes. And people point to that and say, gee, Tower, you're out of your mind. This is a rare problem. A few years ago, you were only able to find 25 cases in the literature. What people need to realize is these are the most extreme cases. And this is a spectrum illness. And for every one of those case reports, there's likely 100,000 patients with a lesser degree of illness related to this entity. And not to mention that not all cases get written up, even if they are in a very severe form. I revisited this because the British Medical Journal recently published an editorial by a professor surgeon in England. It's a Mr. Surgeon. They call their surgeons misters and not doctors, who basically was a little bit irritated that the British MHRA had expanded the monitoring criteria just for the local hip problems and expanded it to hip resurfacing, metal-on-metal hips. He didn't disclose that he was a paid consultant for Smith & Nephew, who makes the Birmingham hip, or Corin, that makes another resurfacing metal-on-metal hip, as well as a resurfacing shoulder device. And strangely enough, this appeared in the British Medical Journal, which is highly reputable, as a commission commentary that was not peer-reviewed. But he had the temerity in one sentence to dismiss the existence of systemic cobalt poisoning from metal-on-metal hips, which are the ones that we know cause the problem. So I went back and looked at what's happened to the literature since the Gesner case report, the systemic literature review of 25 cases. Well, just a cursory review, I found 8 more cases reported in the interval, all of them presenting in heart failure, 3 of which died, 3 of which required heart transplantation, and a litany of other procedures to the survivors. So what we're seeing over time is kind of an exponential increase in these extreme case reports. And again, for every extreme case report, there's probably 100,000 patients with a lesser illness. Since that time, we're getting more and more series of patients that are exposed to cobalt at relatively low levels that either have documented mild illness, either by neurologic imaging or by echocardiography. So what do you guys do for your patients? What do you recommend to your friends and family that had a hip replacement done 10 years ago and now they're French fries short of a Happy Meal? They need a urine cobalt level. If their urine cobalt level is 1 or greater, I consider them cobalt positive. And then I get a blood cobalt level. Because those were the criteria that we used in the 101 patients that we know and have studied well. If the patient has a urine cobalt level of 1 or greater, and they're a French fry short of a Happy Meal, in my office, the next thing we do, and I talked to the patients a long time about this, I recommend they get an FDG PET brain scan. Because at this point, I think that is the most diagnostic entity for the systemic toxicity. And if that patient is showing that their brain metabolism is likely being affected by cobalt, then I feel a lot better about discussing revision surgery with the patient, which can be a complication and high-risk procedure, particularly in an elderly individual. And that's pretty much what we just talked about. How did we get in this fix? We're looking at 4 million Americans at risk for their hip replacement, and it's because nobody ever looked. None of these devices have had to go through rigorous pre-market studies to show that they are not toxic. Most of them are grandfathered in because they resemble some sort of device that predated even the pre-market approval process at the FDA. So it's very easy for manufacturers to continually alter these devices, and the alterations are not necessarily well studied. marketing, free market medicine has a huge role to play in this. New sells. Believe me, new sells. It sells to surgeons, it sells to patients. You tell the patients you're doing something that's brand new, it's a kryptonite hip, and you're going to put it in through the belly button. Patients are going to line up at your door. And it's very interesting because there's no literature support in joint replacement to suggest that new is better. It's quite the opposite. What's been around for 30 years is what we know. And we know there's designs of hips that have been around for more than 30 years or 30 years and longer that have survivorships on total joint registry data that's better than any of the new stuff. You could make a strong argument that everyone would be better off if we stopped innovating in total hip replacement and stuck with the devices that have the best 20-year survivorship in total joint registries, because those devices fail at an exceedingly low rate. And to your left is an example of one of those early, very well-proven devices, stainless steel. There's no chrome cobalt. There's only 2 parts and 3 materials: polymethyl methacrylate cement, polyethylene, and stainless steel. That's the Charnley low friction hip arthroplasty. It is out surviving almost every hip done in American operating rooms today. And if you look to your right, you'll see how complex the new devices have become. Again, any way you cut it, if you do cost-benefit analysis, and the NICE Institute in the UK did this for hip resurfacing, which remains very, very popular. Some patients will travel to the ends of the earth to get a hip replacement, hip resurfacing done, which is a metal-on-metal device. There's absolutely no scientific evidence to support the use of that device in any population, period. If you go with science, if you look at total joint registry, if you look at the NICE cost-benefit analysis, there is an incredible drive in this country to use unproven, more complex, more expensive implants routinely, even in the elderly. And I have seen elderly patients fail a hip at 5 years after surgery because of bad design and bad materials, where with a gold standard hip, their chance of requiring a revision surgery due to material failures was 0, established over a period of 50 years of study. Where are we going in this country? It's not getting better, folks. It's getting worse. Patients have had a tendency, not patients, but my colleagues tend to dismiss my work. Well, Tower, your reports are anecdotal. They're trying to hold me to the same standard of medical evidence that should be applied to a new medical device, showing it's safe. I'm just giving case reports and case series showing devices are unsafe. I don't need a double-blind randomized control trial to show a complication exists or a device is unsafe. I just need a handful of patients. And now I have a lot more than a handful of patients. But the trend in Congress has been to take that same anecdotal standard of evidence and apply it to approval of a new device, which is just standing things totally on their heads. So in the United States, I think we're dealing with a market-driven rather than a science-driven enterprise. I think that's what's caused all these problems. I think we already know what works. We need to go back to what works. And we can't expose our patients to the risk of more of this nonsense. And in order for a company to prove that one of their more complicated devices with more parts and pieces with different materials outsurvives a Charnley low friction arthroplasty, they would have to study more than 1,000 patients for more than a period of 10 years in a double-blind randomized fashion because the Charnley fails at such a low rate. Industry can't afford to do that. So we're stuck with more of a retrospective style analysis. The cost of this is immense. The cost was immense with the metal on metals, and a lot of that is a sunken cost, because I think my belief is that industry and orthopedic professional organizations have tried to underestimate the problem and just have patients live with the toxicity rather than addressing the toxicity. Now that the problem expands to most other hip replacements with the modular chrome cobalt parts, there's a multiplier. So that's where we're at. And I greatly appreciate your attention, and I would entertain any questions.